My name is Dr. David Maddy from the University of Louisville School of Dentistry, and this is a mini series that I created for dental students that I title Functional Occlusion and Advanced Restorative Concepts. There are three major acknowledgments. Most of the information from this series is from the book called Functional Occlusion from TMJ to Smile Design, written by Dr. Peter Dawson. There will be some content from Dr. Okeson's book titled Management of Temporal Mandibular Disorders and Occlusion, and there are several animations that are inserted made by a company called BiteFX that aid tremendously in the visualization of these concepts. And at the bottom right of each slide will be an acknowledgement icon of where that source of information comes from. This is lecture number 4, and we title it What's Left in the Middle? Posterior Non-Interfering Contact. Remember last time we introduced and started to speak of the concept of the inverted tripod, and that we said that there were two critical stopping points for jaw closure in a perfected occlusion. In the back, it's called centric relation, and it's the posterior determinants by the seating of the condyles. In the front, the anterior contact is the other stop or determinant, and think of it as the front teeth. It's the 6 front teeth opposing the 6 front teeth. Think of it as a three-legged stool. It's stable and it doesn't wobble. These are critical stopping points that cannot go higher. Condyles can't go higher, and anterior teeth cannot go higher. Stopping points. And this is for a perfected occlusion. And if you remember, I told you I like that word because it implies action, it implies it's been improved, and it's defined in a specific certain way. So that's the word we will use in this mini series. Why? Well, it's stable, it's protective, it's comfortable, it's predictable. Do people have it? No, not really. So why talk about it? Because there's times, again, here's your treatment plan. We'll come to this a little later. There are times that you want to build this perfected occlusion into the occlusal scheme. Dentures, partial extension, partial dentures, extensive restorative procedures, signs or symptoms of occlusal instability, or signs or symptoms of parafunction or dysfunction, hopefully during ortho and during splint. These are times that it's advantageous to take advantage of stability, protection, comfort, and predictability. We started initially by talking about the back, and we spoke of the key points in that lecture was that the lateral pterygoid has an antagonistic and a protagonistic role. And that's important because this is what normal, healthy, functional lateral pterygoid looks like. And we're going to be comparing that next lecture specifically to dysfunction. We also said that the condyle has a positive stop. It's a bony stop. Of course, there's a disc there. And it would be the medial pole of the head of the condyle against the medial wall of the articular eminence. It's a positive stop, cannot go higher. Think of it as an apex. Then we talked about the front, and we talked about their needing to have stable holding contacts. We want an anterior guidance that has immediate separation of posterior teeth. We talked about the neutral zone, and the teeth must be in harmony. And then we went into greater detail about this thing called the envelope of function and how important it is that you do not create your anterior guidance that interferes. So today we're going to talk about what's left in the middle, the really last part for the perfected occlusion. And it really is the simplest. And so we're going to start with principle number 1. We want to create stable, equal intensity stops directed down the long axis of the tooth. We want it to be stable, have equal intensity, and be down the long axis. This picture here shows what we call cusp fossa contact. And you'll see that the lingual cusps and the maxillary, which are the working cusps, will oppose and touch the fossas or the flat spots or the marginal ridges of the mandibular, and that the mandibular buccal cusps, which are the working cusps, will have contact with the flat spots of the maxillary teeth in the posterior areas. A stable holding context would look like this. cusp tips. Again, this is the maxillary, and so the lingual cusp tip would be opposing buccal flat spots, and the buccal cusp tips of the mandibular teeth are working would oppose flat spots in the maxillary teeth. This is how it would look in a completed full mouth case with all crowns, and this is beautifully done. Lingual cusp tips and flat spots. Destructive tooth contacts look like this. Now compare this picture to the picture on the right. Notice that in the destructive, where the teeth are worn, the lingual cusps are in contact. The lingual cusp are the non-working cusps. And in the picture to the right, there is no contact. Also notice the working cusps on the picture on the left have broad contact. Not only do they cover the tip, but they cover the inclines. And also notice that the front teeth have a wide, broad contact. These are destructive. We want them to look more like the picture on the right, point tips and thin lines. We want them to have equal intensity. And equal intensity can be difficult to determine, but one thing to look for is what we call a bullseye. So if you see in the center of the small working tip, let's say, contact, if you have a hollow spot that looks like white with the color of the ribbon around it, then that is likely tall. So just adjust that area. Another tool that has value when we really care about finalizing equal intensity is a device called a tech scan. It's a measuring device, it has film on it, and you bite into it, and it gives you a computer image of where it's hitting heavier than others. It's a good tool for finalizing maybe a case or maybe even a splint. We want this contact to be down the long axis. Teeth are designed for function down the long axis. You see the stable picture on the left? When the teeth make contact in the back, the forces go down the long axis. On the right, the contact occurs on an incline, which is not down the long axis. And in this case, it shows that it's causing a little bit of mobility in order for that tooth to have final closure. Principle number 2. We want to make posterior teeth that are non-interfering. And so look at this picture here. You'll see that the green lines are lined up, which means that that condyle is in the most seated superior position. And then we're going to close like we have shown you in the end of the previous lecture about the dilemma that I call it. We'll see that in this case, the posterior teeth is going to be in the way. So let's say we can put in a new filling or a crown, and initially the condyle was able to seat, but now we have ourselves a tooth that is interfering with that seating of the condyle. So let's run this animation and show you that when it closes, it hits and it gets in the way. Sometimes this causes some grinding and such. We'll come into this greater and more detail later. If posterior teeth interfere, then there can be pain. The rubbing can cause a inflammation of the pulp tissue and cause pain. Sensitivity, it could be sensitivity to cold or hot or chewing or even throbbing. It could get quite intense. But to interfere, we could have pain. Or maybe mobility will occur. If it's not down the long axis and it hits on an incline, then we could get some slight mobilities. Wear occurs, the grinding and the rubbing back and forth because they interfere, wear teeth and cause cusp tips to shorten and blunt and look more like that destructive bite picture that I showed 2 slides ago. Or fractures. Most common reason for posterior cusps to break is that they're in the way, they're rubbing, and it just snaps off the cusps. So the key point is create posterior teeth that the patient cannot rub. Let's look at these possible scenarios in this video. Notice that initially the canine is tall and there is immediate posterior separation, and when this patient goes into right canine protected mode, the posterior teeth cannot touch. But then some things occur and the teeth start to wear until it reaches the point that the posterior teeth are now part of the function in lateral movements. So we end up with a group function. And if we look at the top picture, you'll see that we'll have a group function, and we'll also pick up some bouncing contacts on the opposite side. So we're going to zoom in here a little bit, and we're going to grind to the right back and forth. And we're going to see that because the canine doesn't separate anymore, the posterior teeth are rubbing, and you could get tenderness and soreness, or as they rub back and forth, you can get wear. But the key is the guidance is gone in the front, and we're into a group function and a bouncing contact. You can see that we can get some mobility, picking up inner inclines on the buccal and the lingual, or we can get even abfractions as it torques the tooth and the buccal bone thins, and then we start to chip off and we get abfractions. And then lastly, we're going to show you how the teeth can crack and break. But the key to this video is to show you that the posterior teeth are rubbing and grinding and back and forth. Now, you remember a couple lectures ago, I played you a slide where Dr. Cranham was speaking, and he spoke of causative factor number 1, which was microorganisms. And then he spoke of causative factor number 2, occlusal overload. I'd like to play that again for you. I want you to hear it one more time. And again, I want you to see all the different possibilities that could occur if there is an interference in the posterior.
The other causative factor that I want you to think about is the force on the teeth. And so what I want you to start grasping is that if we have a high tooth or a tooth that's interfering with the mandibular movements and the tooth is rubbing, and we'll talk about why this occurs, we can actually set up this problem where we get not only an increase in muscle activity, but a hyperactivity of the muscles and incoordination of the muscles, where we start putting extra force on the system. And what's intriguing about this is that you could, if you somehow in a laboratory, if you took 10 people and you could set up the same occlusal interference on the exact same tooth, it's very likely that the 10 people would break down 10 different ways. Somebody might break that tooth, somebody might wear that tooth, somebody else might work it loose, somebody else might break bone around the tooth. Other people might avoid the contact and start getting the muscles sore. Other people might get an issue with the joint where the disc starts popping around and clicking. You might have all the things going on, and yet other people adapt. Other people just adapt to it, and that's sort of the miracle of the system. But I want you to start thinking about causative factor number 2 being stress to the system. Not stress like I hate my mother. I'm talking about force, all right? I'm talking about force generated from muscle activity. So stress is going to equal occlusal overload, which is going to lead to what we're going to determine or call occlusal disease. And this is a concept that I really didn't start understanding till getting out in school, but there are people out there that will have the propensity to tear up your work. And so if they're one of those folks that tends to brush and grind and parafunction, we have to start understanding there are ways that we can make the teeth fit together. There are principles that we can follow to better balance the bite and put appropriate forces on the teeth. That's what occlusion is about. That's what it is.
We want posterior teeth that don't interfere with the TMJs in the back. And this animation will illustrate that. You see that the green lines are connected, which means that condyle is completely seated. And now I'm going to run the animation, and the jaw is going to open. And when it closes and full contact occurs into MIP, then that condyle will still be seated in the most superior position. And so we're going to say that the CO, the first contact, and full contact are the same, MIP. So let's watch this. Condyle seated, teeth come together, and condyles stay seated. So our posterior teeth should not interfere with the TMJs in the back. Also, we want the posterior teeth not to interfere with the anterior guidance in the front. And so I'm going to run this animation. You're going to see that when the patient slides to the forward anterior position or protrusion, the posterior teeth are not in the way. They separate out. back and forth. Posterior teeth are not interfering. Anterior teeth are discluding. To the canine, to the right and left, no posterior teeth contact. These posterior teeth cannot rub because they don't interfere with the complete seating and they don't interfere in any of the lateral movements or forward movement. If we have that, we have a peaceful neuromusculature. Let's look at the picture one more time of if there is no interference in posterior teeth. This will become more important next week when we speak of dysfunction. Just watch this again. You see that lateral pterygoid? When it's time for translation to occur, the lower belly, the inferior belly contracts and pulls, and then the superior belly relaxes so that that disc can rotate to the top. And when closure occurs, the superior belly has to contract to reposition that disc forward. And when it's all said and done, and that condyle is completely seated, that lateral pterygoid is relaxed. And we'll see next week what happens when that lateral pterygoid cannot relax. The benefit is, though, when it can, the elevator muscles are shut down, and there is not an excessive amount of hyperactivity or tonicity. And we have the benefit of this. The benefit is that destructive forces are eliminated. Remember, occlusion is about force management. And then if we can do things in our design to minimize forces, then we can have more protection. Just as Dr. Cranon said, there's ways that we can design our bite or our occlusion for protection when we need to manage destruction that is occurring. So, back teeth really are the problem. And they get in the way two different ways, as I said. They interfere with the complete seating of the condyles, or they make contact and excursion movements. What's the net effect of the teeth and the muscles if this possibility is there? Well, it could be that destruction occurs. So let's go back to this case I showed you in the very first lecture. And let's zoom back in. Let's look at that molar. And look at the big wear facet. It's actually on both molars. And when you have a flattened wear facet like that, that means those teeth are rubbing. And so these bacterial teeth are rubbing just like that destructive bite animation I showed you. Broad, heavy contact as that patient grinds back and forth. Well, because they can contact in grinding back and forth, they have more elevator muscle activity and greater force. And so what happens? Well, often what can happen is that front teeth can get tore up. They're thinner, they're not as big and broad and wide. And as this excessive parafunction occurs, the edges of the front teeth can be destructive. And so this picture shows us that the back really is the cause of the problem in the front. So back teeth really are the problem. But we have this dilemma, as I introduced last week, that when that condyle is seated in most people and they close into first contact, which we have called centric occlusion, somewhere in the back touches first. And in order for full closure to occur, which is defined as MIP, that condyle then has to come down that eminence a little bit for that to occur. And so what happens? The lateral pterygoid has to be contracted. If we look at a bite in MIP in the anterior and we have them squeeze, often they'll have contact like this. But if we stop them when they have first contact while the condyle is still seated, there will be often an opening. This is a very large opening and a very large discrepancy. And this is what's most commonly seen. So see if you can follow this. I did it last week. We'll try it again. Since CO and MI are not the same, the condyle cannot stay in CR. So the condyle must translate down the eminence. You should probably stop the video at this point and focus on this and get to the point that this makes total sense to you. Next week, we're going to go into this dilemma a little bit more that I've introduced a few times. We're going to talk about muscle dysfunction. So far we've talked about what is best and good and harmonious and stable. So now we're going to look at what happens when there is dysfunction involved. And then we're going to go into what we're going to call the progressive breakdown of the temporomandibular joint that could occur. And we're going to introduce to you a TMJ occlusion examination.